This presentation has been prepared by Musayev Emin, Docent of Orthopedic Dentistry Department. Complete dentures, instructions and insertion. Insertion stage. Inspection of the finished denture, clinical evaluation of the denture, checking the border extension, checking the support, checking the stability, checking the retention, checking the occlusion, checking the aesthetic, checking the speech, refinement of the occlusion, post-insertion care and instruction. Insertion appointment. In order to successfully complete this appointment, you will need the polished dentures, the articulator with the maxillary remount cast mounted and the mandibular remount cast. Inspection of the finished denture. Evaluating teeth site. Evaluating of the teeth site of the denture base for undercut areas and accuracy of teeth contact. The fitting surface must show no irregularities. The entire periphery should be rounded and highly polished. The edges of the relief area should be rounded. Each denture should be evaluated individually. Before inserting the denture, paint the entire teeth side of the denture base with a thin coat of pressure disclosing paste. Insert and remove the denture when teeth undercuts are present. The paste will be voided from the denture base in the area of teeth contact. When the undercut area is positively established, relieve the denture by grinding with an acrylic burr. Insertion appointment. Examine the teeth side of the dentures and carefully remove any bubbles present with a Kingsley scalpel or other sharp instrument. Prior to delivery, the dentures must be soaked in water for 7 to 2 hours. Insertion appointment sequence. Adjust denture base, adjust denture borders, remount in centric relation, equilibrate in lateral excursion, patient education. Prior to the insertion appointment, the old dentures must be left out of the mouth for 24 hours. Purpose: insertion appointment. The insertion appointment is the process of eliminating errors. Faithfully executing the steps of the insertion appointment will save time and money. Clinical evolution of the denture. Evaluating of borders. Checking for adaptation. Checks at the posterior palatal seal using mouth mirror. There should be no space. Patient is asked to say in exaggerated short bursts. Checking for border extension. Checks are elevated and borders are examined. Buccal and labial mucosa are stretched to check for denture displacement. Checking for frenal relief. Labial frenum is very thin and requires a deep notch. A shallow relief should be given for buccal frena. Evaluating borders. Maxillary arch. Apply a disclosing wax to the border of the maxillary denture in the same manner as the impression compound was applied during the border molding procedures. Instruct the patient to open the jaw as in weighing, push the lower jaw forward and move the lower jaw from right to left. Therefore, overextension can be determined. Relieve existing overextension by grinding and polish the relieved area. Mandibular arch. Apply disclosing wax to the mandibular denture borders. Instruct the patient to repeat the same movement that were made in border molding. Relieve by grinding any overextending areas and polish the relieved surface. Adjusting the denture base. Zinc oxide paste is used as a pressure indicating paste to detect improper adaptation. Here it has been placed into a disposable syringe for easy use. The PIP spray is used in patients with xerostomia and in order to prevent the PIP from sticking to the mucosa. Adjusting the denture base. PIP sequence. Dry denture surface. Brush a thin even layer of PIP onto the surface of the denture. Sit the denture with pressure in the first molar region. Remove immediately. Inspect and adjust bearing surface as necessary. Adjusting the denture base. The PIP pattern indicates severe pressure on the portion of the denture that overlies the torus. Adjusting the denture base. This area is adjusted in with an acrylic burr. When completed, the brush marks are mostly absent and the posterior palatal seal bead in showing. Adjusting the denture base. PIP the mandibular denture. Use smooth, even brush strokes. Carefully insert denture so as. Pay particular attention to the mylohyoid ridge region. Adjusting the denture base. Note the areas of excessive teeth pressure on the labial and buccal slopes on the ridge. These are carefully adjusted with an acrylic burr. When completed with this procedure, most of the brush marks should be obliterated and there should no areas of teeth displacement notes. Adjusting the denture borders. Disclosing wax is used to check the length on the denture borders. In this example, it has been placed in a disposable syringe. Temper the wax in the syringe in a water bath. Apply disclosing wax to the dried denture border. Carefully insert the denture and mold the borders of the selected area. Adjusting the denture borders. Carefully adjust the denture flank as necessary. Apply border mold and adjust until areas of overextension are eliminated. Adjusting the denture borders. Other examples of commonly overextended areas. These flanks are too thick. These flanks are too long. Evaluating the retention and stability of denture. Retention. By applying dislodging forces as attempting to remove the denture. Posterior palatal seal is checked by gently pressing the anterior teeth perpendicular to the path of insertion. If adequate, we can feel the resistance. Stability. Using the fingers pad, applying pressure on the occlusal surface at the premolar region on each side alternatively. If that caused the denture to tilt, rock, and dislodge from the ridge at other side, this may indicate that there is a problem in stability, as if the teeth was positioned buccally. Anterior seal is checked by pulling against the path of insertion. Occlusion in complete denture, prosthodontics. Index. Introduction, concepts of complete denture occlusion, balanced occlusion, lingualized occlusion, monoplane occlusion, disclusion of teeth arrangement under various occlusal schemes. Summary references. Introduction. Definition of occlusion, history, development of dental occlusion, biomechanics of occlusion, differences between natural and artificial occlusion, review of literature. Introduction. Occlude means to close. The static relationship between the seizing or masticating surfaces of the maxillary or mandibular teeth or tooth analogs GPT 8. The act of process of closure or of being closed or shut off. Any contact between the incising or masticating surfaces of the maxillary and mandibular teeth. Occlusion is an important factor which governs the retention and stability of the complete denture in vivo. Terminologies. Centric occlusion, the occlusion of opposing teeth when the mandible is in centric relation. This may or may not coincide with the maximal intercuspal position. Centric occlusion, an occlusion other than centric occlusion, maximum intercuspation, complete intercuspation of opposing teeth independent of condylar positions, exclusive movement, movement occurring when mandible moves away from maximum intercuspation. Balancing side or non-working side, the side of mandible which moves during median line during lateral excursions. Balancing interferences. Undesirable contacts occurring of balancing side during lateral movements. History. Mammals evolves from a group of mammal-like reptiles about 218 and 119 million years ago. Reptiles cannot bring their upper and lower teeth together and cannot chew. Their teeth cannot move because they are ankylosed. But by the time the earliest known mammal had evolved, these now had two sets of dentitions, and the upper and lower teeth could be occluded. Diffiodontia 1 replacement set IU2 dentitions probably evolved as a result of the increasing efficiency of the dentition created by the use and wear of teeth that would share against each other. There is no point in producing a succession of such inefficient dentitions as every newly erupted molar, because of its high and worn cusps, would have disrupted the smoothly efficient shears edges which are created by attrition. Early wear of teeth in a gorilla. Early wear of teeth in a human who lived about 1000 years ago. The wear has produced sharp edge of enamel on the first molar, which is very efficient for shearing and cutting of coarse food, and the flatter occlusal surface allows for efficient grinding. This person was a coastal dweller and lived on a variety of foods, including fish and crustaceans. The other teeth still have enamel occlusal surfaces. A deciduous dentition also helps to solve the problem of providing a child with a most effective masticatory apparatus appropriate to their needs at that time and consistent with the space available in the jaws. The potential functional weakness of a transition period is minimized by the sequence of events. When the central incisors are lost, the deciduous lateral incisors and canines can be used to incise food, whilst loss of the deciduous molars does not prevent crushing and grinding because the first permanent molars are already in place. The earlier development of a gum for this periodontal ligament type attachment allowed the position of each tooth to be adjusted after eruption in response to force product during chewing, so that it normally ends up in the most efficient position. Development of dental occlusion. The term occlusion is derived from Latin word occlusio, defined as the relationship between all the components of the masticatory system in normal function, dysfunction, and parafunction. An ideal occlusion is the perfect interdigitation of the upper and lower teeth, which is a result of developmental process consisting of the three main events: jaw growth, tooth formation, and eruption. Occlusal development can be divided into the following development periods: neonatal period, primary dentition period, mixed dentition period, and permanent dentition period. The first lasts up to 6 months after birth. Two period is from around the 6 months to 6 years. A three period is around 6 years to 12 years, and fourth period is over 12 years onwards. Consistency in pattern development. Layton has shown that the upper anterior gum pad intercuspid width is typically wider than the lower anterior pad, and the upper anterior gum pad protrude overjet about 5 mm relative to the lower anterior gum pad. The upper anterior gum pad usually overlaps overbite the lower anterior pad by about 0.5 mm. In the first 6 months of postnatal life, there is marked palatal width increase and the overjet decreases rapidly. Primary dentition terminus. By 3 years of age, the occlusion of 20 primary teeth is usually established. The relationship of the distal terminal planes of opposing second primary molar teeth can be classified into one of three categories: flat terminal plane, distal step, mesial step. Dental arch relationships. The maxillary arch is usually wider than the mandibular arch. Maxillary cusps. Mandibular cusps. Adduced keys to normal dental occlusion present in natural dentition. Consists 5 keys. Keys 1, molar relationship. Keys 2, crown angulation. Keys 3, crown inclination, torque. Keys 4, rotation. Keys 5, tight contacts. Case 6, curve of Spee. Consists 6 case. Case 1. According to Andrew's definition, normal occlusion exists when the mesiobuccal cusp of the maxillary first permanent molar occludes in the groove between the mesial and middle buccal cusps of the mandibular first permanent molar. Key 2. The gingival portion of the crowns of all teeth is more distal than the incisal or occlusal portion of the crowns. The long axis of all crowns of the teeth, with the exception of the molars, is considered the main mid-development ridge of the facial surfaces of the teeth. The long axis of the crown of the molar teeth is considered to be the buccal groove and its extension to the gingiva. Key 3. Crown inclination. This refers to the labiolingual axial inclination of the anterior teeth and buccolingual axial inclination of the posterior teeth. In upper incisor, the gingival portion of the crown's labial surface is lingual to the incisal portion. In all other crowns, including lower incisors, the gingival portion of the labial or buccal surface is labial or buccal to the incisal or occlusal portion. Key 4. Rotation. The fourth key to optimal occlusion is absence of tooth rotations. Key 5. Tight contacts. There should be no spaces between the teeth. Contact points should, but unless a discrepancy exists in a mesiodistal crown diameter. Key 6. Curve of spee. The depth of the curve of spee should be fairly flat, ranging from 0.5 mm to 1.5 mm at its deepest point. An average curve of spee is 1 mm. Biomechanics of occlusion. Jaw movements. Only the mandibular arch moves, working lateral intrusive movement towards the side that the mandible moves towards, non-working medial intrusive balancing movement, not the side that the mandible moves towards, protrusion moving the mandible forward in an anterior-posterior plane, retrusion moving the mandible backwards in an anterior-posterior plane. Mandibular movement. Mandibular movement can be broken down into a series of motions that occur around three different axes. Mandibular movement. Various mandibular movements are composed of motion occurring concurrently about one axis or more. Mandibular movement. The up and down motion of the mandible is a combination of two movements. Pure hinge movement occurred as a result of the condyles rotating in the lower compartment of the TMG within a 10-30 degree arch, which creates a 20-25 mm separation of the anterior teeth. Mandibular movement. There is also some gliding translation movement in the upper compartment during maximum mouth opening. Mandibular movement protrusive. When the mandibular slides forward so that the maxillary and mandibular anterior teeth are in end-to-end relationship, it is in a protrusive position. Ideally, the anterior segment of the mandible travel a path guided by the contacts between the anterior teeth with complete disocclusion of the posterior teeth. Mandibular movement. Lateral excursion. Mandibular movement to one side will place it in working side, and the other side will be the non-working side. In this type of movement, the condyle on the NW side will arc forward and medially. The condyle on the working side will shift laterally and slightly posteriorly. Bennett movement. During lateral excursion, the bodily shift of the mandible in the direction of the working side was first described by Bennett. The angle formed in the horizontal plane between the pathway of the NW condyle, the mandibular translation, and the sagittal plane is called the Bennett angle. Postals envelope of motion. Maximum protrusion, protruded contact position, edge to edge position of incisors, centric occlusion, maximum intercuspation, centric relation, protruded contact position, rest position, chewing stroke, rotation, terminal hinge axis opening, translation, maximum opening. Difference between natural and artificial occlusion. Natural teeth, artificial teeth. Natural teeth, artificial teeth. Ideal requirements of complete denture occlusion: stability of the denture and its occlusion when the mandible is in both centric and eccentric relations, balanced occlusal contacts, unclogging the cusps mesiodistally so that the denture can settle down when there is reached resorption. Functional lever balance should be obtained by vertical tools to reach crest relationship, cutting, penetrating, and shearing efficiently of occlusal surface, minimal area of contact, incisal clearance during posterior functions, sharp reaches, cusps, and stool ways to increase masticatory efficiency. Occlusal schemes requires to fulfill the requirements. Occlusal schemes has three requisites: 1. Incisive units, 2. Working units, 3. Balancing units. Incisive units included all four incisors, sharp units for increased incising efficiency. Units should not contact during mastication, they should only contact during protrusion. Shallow incisal guidance, increased horizontal overlap to avoid interference during setting. The mandibular denture may slide anteriorly as it settles. Working units: cusps for good cutting and grinding efficiency, smaller buccolingual widths to decrease the occlusal load transferred to the tissues, group function at the end of the shearing cycle during eccentric position. The occlusal load should be directed to the anteroposterior center of the denture. The plane of occlusion should be parallel to the mean foundation plane of the ridge. Balancing units: second molar should be in contact during protrusive action. They should have contact with the working side at the end of the shearing cycle. Smooth gliding contacts should be available to uninterested lateral and protrusive movements. Occlusal schemes have been classified into nitrocentric occlusion, lingualized occlusion, non-anatomic occlusion, monoplane occlusion with balance, linear occlusion, balanced occlusion. Balanced occlusion: the bilateral simultaneous anterior and posterior occlusal contact of teeth in centric and eccentric positions. It is not seen in natural dentition. Characteristic requirements of balanced occlusion: all the teeth of the working side, central incisor to second molar, should glide evenly against the opposing teeth. No single tooth should produce any interference of disocclusion of the other teeth. There should be contacts in the balancing side, but they should not interfere with the smooth gliding movements of the working side. There should be simultaneous contact during protrusion. Importance of balanced occlusion. Balanced occlusion is one of the most important factors that affect dentistry stability. Absence of occlusal balance will result in leverage of the denture during mandibular movement. Shepard stated that interbolus exit balance. According to this statement, the balancing contact is absent when food entered the oral cavity. This makes as think that balanced occlusion has no function during mastication, and it's not essential in a complete denture, but this is not true. On an average, a normal individual makes masticatory tooth contact only for 10 minutes in one full day compared to 4 hours of total tooth contact during other functions. So for these 4 hours of tooth contact, balanced occlusion is important to maintain the stability of the denture. And hence balanced occlusion is more critical during parafunctional movements. General considerations for balanced occlusion. The wider and larger the ridge and teeth closer to the ridge, the greater the lever balance. Wider the ridge and nowhere the teeth buccolingually, greater the balance. The more lingual the teeth are placed in relation to the ridge crest, the greater the balance. The more centered the force of occlusion anterior-posteriorly, the greater the stability of the base. Types of balanced occlusion. Occlusal balance of balanced occlusion can be classified as follows. Unilateral balanced occlusion, bilateral balanced occlusion, protrusive balanced occlusion, lateral balanced occlusion. Unilateral balanced occlusion. This is a type of occlusion seen on occlusal surface of teeth on one side when they occlude simultaneously with a smooth, uninterrupted glide. This is not followed during complete denture construction. It's more pertain to fixed partial dentures. Bilateral balanced occlusion. This is a type of occlusion that is seen when simultaneous contact occurs on both sides in centric and eccentric positions. Bilateral balanced occlusion helps to distribute the occlusal load evenly across the arch and therefore helps to improve stability of the denture during eccentric or parafunctional movements. For minimal occlusal balance, there should be at least 3 points of contact on the occlusal plane. More the number of contacts, better the balance. Bilateral balanced occlusion can be protrusive or lateral balance. Clinical remount. Purpose. To correct for the fact that adjusted denture bases sit more accurately than record bases. Accommodate for errors made during the making of centric relation records. Measure twice, cut once. Clinical remount. Sit the posterior palatal seal, place 2 cotton rolls between the posterior teeth and have the patient back down for 5 minutes. Clinical remount, lingualized occlusion. The maxillary denture has already been mounted on the articulator with the plaster remount cast and maxillary faceball transfer jig. Clinical remount, lingualized occlusion. Place compound sticks in the water bath at 105 degrees and make sure you use enough compound to cover the posterior teeth. Apply the melted compound to the occlusal surfaces of the posterior teeth. Clinical remount, lingualized occlusion. Make centric relation record and prove the record. Carry to mouth and have the patient close in centric relation just short of tooth contact. While making the record, instruct the patient to retute and elevate the tongue. This will ensure that the condyles are properly seated while making the record. Clinical remark: lingualized occlusion. Remove the record, chill in cold water and trim so that only the cusp tip indentations remain. Trim the buccal side so that seating of the dentures can be visually checked. Clinical remark: lingualized occlusion. Return the record to the mouth and recheck the record. Contact should be equal and simultaneous bilaterally. If not, repeat the record. Observe the maxillary denture as the patient closes. If the denture moves during close, repeat the record. Clinical remount: lingualized occlusion. Using the remount casts, the dentures are mounted on the articulator. Make sure to lock the condyles in centric while remounting the dentures. Clinical remount: lingualized occlusion. Begin by equilibrating in centric relation. If your original centric relation record was correct, little or no adjustment will be necessary. Clinical remount: lingualized occlusion. Make a protrusive record. Instruct the patient to bring their mandible forward 8 or 10 mm when making the record. Evaluation of row relation. Row relation are once again verified. Centric relation is verified. Vertical dimension is verified. Clinical remount: lingualized occlusion. Protrusive record. Transfer the record to the articulator and insert one of the protrusive inserts. Hold the upper member of the articulator down into the record and adjust the condylar inclination. Clinical remount: lingualized occlusion. Protrusive record. A steeper insert 30 degrees was eventually chosen. The dentures are seated in the protrusive record and the condylar shaft is in contact with the protrusive insert. We are now ready, if necessary, to equilibrate in excursions. Clinical remount: lingualized occlusion. Check excursions. This is protrusive. If necessary, adjust the occlusion to restore bilateral balance. Clinical remount: lingualized occlusion. Bilateral balance in lateral. Centric balancing working. Lingualized occlusion. Indication for use: high aesthetic demands, severe mandibular ridge atrophy, displaceable sporting tissues, malocclusion, previous successful denture with lingualized occlusion. Adventures: good aesthetics, freedom of non-anatomic teeth, potential for bilateral balance, centralized vertical forces, minimizes tipping forces, facilitates bolus penetration, mortal and pestle effect. Clinical remount: monoplane occlusion. Use eccentric relation, record and the remount cast to mount lower. Clinical remount: monoplane occlusion, natrocentric, equilibrate in eccentric first. Clinical remount: monoplane occlusion, natrocentric. When complete, all of the maxillary and mandibular posterior teeth plus the central incisors will be on the occlusal plane. Clinical remount: monoplane occlusion, monoplane with balancing ramps. Balancing ramp is incorporated into the denture base. Equilibrate in centric as before. Clinical remount: monoplane occlusion, protrusive balancing working. equilibrate in working, balancing and protrusive. Evolution of denture aesthetics: sleep, support, cheek, support, vertical head, low lip line, high lip line, smile line are examined. Rating of speech: the patient is asked to speak or read aloud. If there is any error in the denture, patient will have difficulty in pronunciation of certain words. Paper baby 6655, counting from 50 to 60. Post-insertion instructions. Appointment schedule. First appointment within 48 hours of delivery. Second appointment within 3 days. Third appointment within 1 week or of second visit. Different experiences and discomforts to be explained to patient. First oral feeling of fullness, retention, comparison between natural and artificial teeth, saliva, increase of salivation, speech change, eating specific type of manner, tongue position and problems with the lower denture in contrast with the upper denture. A list of instructions. Wearing of dentures and habituation, denture hygiene and care, eating habits, speech, gagging. Patient management. Explain the following to the patient: limitation of the dentures, expected teeth response, care of the aesthetics and tissues, desirable follow-up treatment. Hard classification of patients: philosophical, exacting, indifferent, hysterical. 24-hour check. You are about the patient's problems and conduct a thorough oral examination. Check the denture for pressure areas and adjust the denture as needed with PIP. Check borders for overextension with disclosing wax and adjust as needed. Alert occlusion, refine equilibration as necessary, and recheck, finish and polish. Classification of post-insertion denture problems. Most of the complaints associated with the complete dentures are actual and non-physiological, contrary to the belief of most clinicians. There was no statistically significant relationship between patient age and systemic health and denture complaints, but statistically significant relationship exists between types of denture, denture faults, and complaints. Classification of post-insertion denture problems. Complaints about comfort of the denture. Sore spots, burning sensation, redness, pain in TMG, tongue and cheek beating, swallowing and sore throat, nausea and gagging, deafness, fatigue of the muscles of mastication. Complaints about function of the denture, instability or poor feet, interference when swallowing, clicking, complaints about aesthetics, fullness under the nose, depressed philtrum or nasolabial sulcus, upper lip sunken in, too much of teeth exposed, artificial look, pain about phonetics, whistle on C sounds, lisp on C sounds, indistinct or TH and T sounds, T sound like TH, F and V sounds indistinct. According to Shari, frequent complaint, excessive bulk, speech difficulties, masticatory shortcoming, insufficient retention, causal irritation, attractive appearance. Common complaints: wasting, ear ache, difficult swallowing, loss of taste sensation, saliva under the dentures, regular taste, food under the denture, dislodgement on sneezing, dislodgement on drinking, drooling at the corner of the mouth, inability to chew with equal vigor or both sides, rude and sharp surfaces, dull teeth, halitosis, dry mouth, nosely teeth, jack lip and tongue beating, although and gagging, tingling of the lower lip, burning of mouth. According to Grant, post-insertion problems can be broadly grouped into looseness of dentures, decreased retentive forces, increased displacing forces, discomfort associated with dentures, related to impression surface of denture, related to occlusal surface, related to polished surface, related to possible systemic association. Support problems, problems associated with retention and stability. Other difficulties, noise or eating and speaking, speech problems, eating difficulties, altered taste sensations, gagging. Denture complaints in relation to time of delivery, immediate complaints, delayed complaints, problems without complaints. Presentation of patients with complaint. Informed patients of possible problems, uninformed patient, sense of pain, sense of loss, waste of time and money, sense of sad. Pain, overextension of borders, poor fitting or rubbed surface dentures, error during impression making, incorrect centric relation or cuspal interference, excessive vertical dimension, uneven occlusion balance and anterior contact at CR, inadequate relief to the prominent genial tubercles and millet reach. Loose denture. PPC is not successfully made. Lingually placed posterior teeth, labially placed mandibular anterior teeth, dryness of mouth, occlusal discrepancies, inaccurate impression making, walking, tilting dentures, poor retention, Nodules of acrylic, faulty impressions, poor processing techniques, faulty aesthetics, unrealistic expectations, over-supported or under-supported dentures, altered vertical dimension, defective speech, increased vertical dimension, deficiency of palatal contour, poor PPC region, thick lingual flange or restricted tongue movements. Inappropriately, discrepancy in vertical dimension and CR, worn of teeth, 0-degree posteriors, lack of occlusal balance, occlusal plane C at higher level, nose and gagging, overextended posterior limit of maxillary denture, thick posterior borders or loose denture, uncommon belief, fibrous hyperplasia, continuous wearing of ill-fitting denture, usually painless, microbial infection, poor oral and dental hygiene, maintenance, diabetes and oral habits, Constance syndrome, prolonged overclosure, deafness, tinnitus, tenderness over TMG, dryness of mouth, neurologic symptoms, burning sensation of tongue, throat, and headache. Common complaints: whistling, high wall palate, ear age, TMG problem, food and saliva under denture may be deficient of borders, loss of taste, cheek beating, lack of horizontal overlap, decreased VD or buccal placement of teeth, rolling saliva, inadequate VD, allergy, pigment or residual monomer of denture resin. Complaints about comfort of denture, causes and treatment. Complaints about functions and denture of the denture, causes and treatment. Complaints about phonetics, causes and treatment. 24-hour check. Ask the patient. Wearing of dentures and habituation. Within 2 or 24 hours of wearing dentures, little discomfort will be there, leading to soreness, and there will be excessive salivation, which has to be swallowed. Denture removed 8 hours every 24 hours. The resulting force can be damaging to the teeth. During the rest period, the denture should be kept in water or dilute mouth antiseptic. If any pain, ulceration and or burning sensation after wearing denture occurred, consult dentist. Before sleeping, soak the denture overnight in fresh, clean water. Denture should not be soaked in hot water. This can cause thermal change and can distort dentures. Avoid the occlusion. Open contact. If you observe change, repeat the clinical remand procedure. Complete denture manipulation. Neuromuscular control may be the single most significant factor in the successful manipulation of complete dentures under function, tongue function, and denture wearing experience, and important prognosis indicators. Common problems: mandibular denture discomfort, poor retention and stability, lack of support; maxillary denture, poor retention and stability, aesthetics and phonetics. Discomfort may be secondary to open vertical dimension of occlusion, inaccurate centric relation record, lack of occlusal balance, poor denture base adaptation, inappropriate denture base extensions. Retention and stability compromised by occlusal discrepancies, poor denture base adaptation, inadequate denture extensions. These factors are controlled by the dentist. Retention and stability also affected by moderate to severe resorption, unfavorable floor or mouth posture, retruded tongue position, reduced salivary flow, poor neuromuscular control. These factors are beyond the control of the dentist. Possible solutions: osseous-integrated implants, denture gives permanent soft liners. Dentures retained with osseous-integrated implants, denture adhesives, power cream and pads, permanent soft liners, silicone elastomers. Speech. Speaking with new dentures requires practice, so read out loud and repeat the words those which are difficult to pronounce. With time, speech will be better with dentures. The acts of coughing and sneezing often dislodges the denture and result in an embarrassing situation. Embarrassment can be avoided by covering the mouth with a hand to prevent denture from coming out. Problem with phonetics. Complaints with aesthetics. Egging. Denture hygiene. Rinse mouth properly before wearing dentures. Dentures must be cleaned properly before and after meals using denture brush. Clean tongue and skin over the bone properly and massage the skin over bone gently using clean finger. Inside surface of dentures must be cleaned delicately using clean finger, wet cotton. It is showed they should not use any patient should not use any abrasive and detergents to clean their dentures. Patient shouldn't make any adjustment or repair by himself. Denture hygiene. Poor denture hygiene can result in causal irritation, inflammatory papillary hyperplasia, denture stomatitis, chronic candidiasis, stains retention, halitosis. Chemical denture cleaners and sonic cleaners for dentures. Manual cleaning, brushing. Think Nutrition and diet. Introduction. Diet is the total oral intake of substance that furnish nourishment and calories to the body. Nutrition is biochemistry and at the cellular level. It is the science of our body utilized food to growth, development and maintenance of tissues and structures. Definition. Nutrition is defined as the study of ingestion, digestion, absorption, transport, metabolism, and excretion of the chemical found in food. Diet. It's defined as the total oral intake of substances that furnish nourishment and calories. Nutrients. These are organic and inorganic complexes contained in food. There are about 50 different nutrients which are normally supplied through the foods. Each nutrient has a specific function in the body. Nutrients classified as macronutrients, micronutrients, and classification of foods. Bodybuilding foods, energy-giving foods, and protective foods. Also be classified as proteins, carbohydrates, fats and lipids, vitamins, minerals, fibers, and water. Xeristomia affects almost 1 in 5 older adults. When salivary levels decline, teeth become more susceptible to dental caries. Exposed root surfaces of teeth are particularly at risk. Also impaired complete denture retention and is associated with increased periodontal disease, burning or soreness of oral mucosa, and difficulties in chewing and swallowing, all of which can adversely affect food selection and contribute to poor nutritional status. Sense of taste and smell. Effects of dentures on taste and swallowing. Nutrition care for denture wearing patient. Impact of dental status of food intake. Nutritional needs and status of elderly. Calcium and bone health. Climacteric. Vitamin supplementation. dietary counseling of patients undergoing orthodontic treatment. Nutrition guidelines for orthodontic patients. Conclusion. Success of a complete denture prosthetic is mainly influenced by the mucosal condition of the denture bearing areas. So the patient has to be well nourished and consume a well balanced diet. Dietary guidance based on assessment of the edentulous patient nutrition history and diet should be an integral part of comprehensive prosthodontic treatment.